audible and visible to all of you. Yes. Boys and girls, confirm me once. All right. Yes. Okay, good evening. So all my dear students, so this session is going to be very important session, very crisp and very concise. In next 60 minutes, we are going to discuss the 25 questions in a test and discussion format, and it will be helpful not only for foreign medical graduates but also for NEET PG, INI, CT students. But my more focus will be on the upcoming FMGE exam so that you are able to get maximum out of it. Yes? Okay. All right. Hi everyone. Dr. Ankita, Dr. Study Live, everyone. Yes. Okay. So what my agenda will be, that we'll be discussing and dissecting each question along with the option. I believe dissecting the option is very, very important. है ना? Our idea will not be to reach towards the answer directly. The idea will be to eliminate the options and try reaching up to the final answer. ठीक है जी, तो ये मेरा एजेंडा रहेगा. तो हम ऐसा करते हैं, अभी हम स्टार्ट करते हैं. आई हैव इंक्लूडेड मेनी इमेजेस, बहुत सारी इमेजेस को मैंने इंक्लूड किया है, सो दैट वी आर नॉट ओनली डिस्कसिंग दैट पर्टिकुलर आंसर आस्क्ड इन द क्वेश्चन बट ऑल्सो सम एसोसिएटेड इमेजेस, है ना. सो यस, so without wasting any more time, let's start with the session. So first and foremost is, which is not the feature associated with the following condition. तो पहले मुझे बता दीजिए what is this following condition. तो can you appreciate, देखो सीधा आंसर नहीं करना प्लीज प्लीज, दिस इज माय काइंड रिक्वेस्ट टू ऑल ऑफ यू. हम सीधा आंसर नहीं करेंगे, हम पहले क्वेश्चन को डाइसेक्ट करेंगे, देन विल रीच टुवर्ड्स द आंसर. तो व्हाट इज दिस, क्या लग रहा है ये, व्हाट इज दिस, दिस यू कैन सी striations. What are these striations? These are actually tears in the DM. DM means, DM is one layer which is Descemet's membrane in the cornea. If there is tears, अब देखिए, these striations are horizontal or vertical striations. Boys and girls, these are horizontal striations. Now horizontal striations which are tear in the Descemet's membrane of cornea, these are known as H for horizontal, H for Harb's striations, Harb's striations. Okay, एक चीज हमें पता लग गई. Now can you appreciate the status of the cornea? कैसा लग रहा है cornea? The cornea is not clear. The right eye cornea is not clear as relative to the left eye. So that means the cornea is hazy kind of. Which appearance? This is your ground glass appearance of the cornea. And also, can you appreciate difference in the size of the two eyes? Can you appreciate this eye? This eye is bigger in size. So this is your boophthalmos. Now, based on the three important clues which are given in this question, can we now discuss the options? Why not, sir? We are waiting for this, sir. All right. So this is a case of diagnosis. Guys, see, my one request to all of you, please don't tell me the answer straightforwardly. Whatever I am asking, you need to tell me that. I know you know the answer. I know you are going to rock FMG exam. You are going to rock any exam that you are going to sit in. But the idea of these conceptual sessions is to rub your gray cells so that you are able to get answer out of the options given. वो होता है ना कि एक पहेली सी आपको दी गई है, डॉक्टर हाउस में जैसे होता था, ग्रेज एनाटॉमी में जैसे होता था, कि एक एक क्लू के बेसिस पे आप अपना डायग्नोसिस बनाएंगे. तो वही करना है यहां पे. आई वांट यू टू बी एक्टिवली present both physically and mentally. Okay, now diagnosis is primary congenital glaucoma. Ab we have got to know the diagnosis ke boss, this is a case of primary congenital glaucoma. Very good, boys and girls, you are writing it correctly. Now what are the features of primary congenital glaucoma? Harb's striae, yes it is there, but they have asked which is not a feature. Harb's striae, yes, the image is already given, so you just eliminate it. Next is congenital glaucoma, raised intraocular pressure. Of course Glaucoma, raised intraocular pressure leading to Harb's striae, boophthalmos, ground glass appearance of the cornea. Now, when there is raised intraocular pressure, it is going to push the lens, yes, due to which the lens may get subluxated or dislocated. That means due to pushing of the lens, there may be breaking of the zonules of the lens, as a result of which the lens may hang down or the lens may literally fall in the anterior chamber or in the posterior chamber. So if the part of the lens is in the normal anatomical position and part of the lens is outside the normal anatomical position, you call it as subluxation. If the entire lens is out of its normal anatomical position, which is known as dislocation. So this also happens. So the answer by elimination is hypermetropia. And what happens in primary congenital glaucoma? I told you na that there will be boophthalmos, increase in the size of the eyeball. When there is increase in the size of the eyeball will have myopia or hypermetropia. It will have hypermetropia. Here it is given myopia. So this is the incorrect option, boys and girls. So hypermetropia is the answer here. So via this we have discussed almost everything about congenital glaucoma. Now can you tell me which is the treatment of choice for congenital glaucoma? बता पाएंगे? Yes, बता पाएंगे? Yes, Dr. Janvi, very good, very good. Yes, there is congenital glaucoma triad, which is lacrimation, which is the earliest sign, photophobia, blepharospasm. Dr. Siddhant is asking difference between congenital glaucoma and boophthalmos. My dear friend, boophthalmos happens in congenital glaucoma. Boophthalmos means bull's eye. Bull's eye means cow and matlab male version of cow. So that is bull na. So it has got big eyes due to raised intraocular pressure. There is expansion of the outer coats of the eyeball leading to bull's eye, boophthalmos. Okay. All right. So I asked you about the treatment of choice. Treatment of choice is goniotomy. But to be able to successfully do goniotomy, you need to have a clear cornea. If the cornea is hazy cornea, you go on for CTT, combined trabeculectomy and trabeculotomy. Yes? Okay. Dear Omkar, bull's eye you are confusing. You are asking drug which cause bull's eye. That is bull's eye maculopathy. That is the condition of the macula, my dearest friend. That is due to chloroquine. Chloroquine causes bull's eye maculopathy. Here I am talking of your boophthalmos. यहाँ पे मैं boophthalmos की बात कर रहा हूँ. All right. Okay. Done. Yes, audio video all clear. बताइए मुझे audio video all clear. Okay. I hope it is not getting disrupted in between. In my phone it was slightly disrupted. Okay, now yes, wonderful. Okay, so this is again, what is this? Ground glass appearance. Can you also appreciate bluish discoloration of the sclera? Actually, due to stretching of the sclera, you are able to appreciate the underneath lying the blood in the choroid, so the sclera appears bluish in color. That is why you see bluish sclera. Yes, but it is not some blue pigment which gets deposited. It is just the underneath blood which you see through the white sclera. Dr. Dhruv Patel, sir, can you explain when all questions are finished about active and passive meiosis and mydriasis of drug agents? Okay, Dhruv, I'll try. Otherwise, you can post this in DAMS-eMedicoz official Telegram channel and tag me. I'll be explaining it to you there. Okay, don't worry. Or you can personally message me. I'll tell you. Okay. Now the second question. I hope you are done with your entire concept of primary congenital glaucoma. Now identify the sign in the given pic. Okay, क्या है ये sign देखेंगे. So what is this sign? What can you see? So you can see that there is some pigment dispersion over what? Over the lens capsule. Now some of you may call it as, sir, this is pseudo exfoliation. And I will say, no, it is not pseudo exfoliation, because in pseudo exfoliation there is a dandruff-like material which you see on the anterior lens capsule, है ना? But here it is a pigment, so it is not. Don't confuse it with pseudo exfoliation. But what are the other options? Now let's move over to the options. So one is KF ring, Kaiser-Fleischer ring. Another is Vossius ring, Fleischer ring and Weiss ring. Now KF ring is the ring, first and foremost, it is present not on the anterior lens capsule, my dear friends. It is present in the Descemet's membrane of the cornea at periphery. So this is eliminated. Vossius ring, I'll be coming upon Vossius ring in a little while. Fleischer ring. Fleischer ring is present on the epithelium of the cornea, and it is seen where? In the cases of keratoconus, and there is deposition of iron. So KF ring and Fleischer ring is eliminated because these two rings are present on the cornea, but here you can see it is present on the anterior lens capsule. Now Weiss ring. Weiss ring is actually seen in posterior vitreous detachment. I am going to show you the images. Don't worry, study live. I am going to show you the images. I told you na in the evening in DAMS-eMedicoz Telegram group that today's discussion is going to be very crisp and very concise. Now check this out. Can you appreciate this brown ring at the periphery of the cornea? So boys and girls, this is your KF ring. But in this case, you saw in the center, that means anterior lens capsule. So what happens is when there is blunt trauma to the eye, there is stamping of the iris on the anterior lens capsule. Due to stamping, there is pigment dispersion on the anterior lens capsule, which leaves a small circular pigmentation ring leading to formation of Vossius ring. So this is seen in your blunt trauma. Okay, but let's discuss. So can you appreciate this brown colored ring which is present on the cornea? Can you appreciate this? Yes, can you appreciate this? This is seen at the base of cone in keratoconus due to iron deposition on the corneal epithelium. Yes, and can you appreciate this? So you can see that this is your optic nerve head. So there are different attachments of the vitreous humor. Vitreous humor is attached to the optic nerve head, macula, superficial retinal vessels, to the posterior surface of lens via Wegert's ligament and ora serrata. Out of these 5 attachments, ora serrata is the strongest attachment. But when there is posterior vitreous humor detachment from the retina, so it leads to formation of a small ring that is a golden colored ring which you see on fundus examination. Can you appreciate the underlying fundus? So this is your optic nerve head. So this is your Weiss ring. Yes. So the answer to this question is your Vossius ring. I hope it is well understood, boys and girls. Sir, इस image के भी periphery में brown like दिख रहा है. किस image की periphery पे, my dear friend? I hope you are clear now. I hope समझ में आ गया है. किस में ब्राउन दिख रहा है? आर यू टॉकिंग ऑफ दिस? देखिए KF रिंग जो है इट विल लाई एट द पेरिफेरी, बट फ्लीशर रिंग विल लाई एट द बेस ऑफ कोन इन केराटोकोनस. सो केराटोकोनस इज व्हेन द कॉर्नियल सेंटर इज थिन सच दैट इट प्रोट्रूड्स आउट. सो यू विल सी द फ्लीशर रिंग हेयर. तो अगर मैं एंटीरियो पोस्टीरियर, इफ आई मेक द एंटीरियो पोस्टीरियर इमेज, दिस इज द स्मॉल कोन and you will see this Fleischer ring here at the base of cone in keratoconus. I hope it is clear, Dr. Study Life. Okay, Study Life appears to be very much convinced with our live sessions, है ना? So he has kept his name. क्वेश्चन वाले इमेज के पेरिफेरी में क्या दिख रहा है? नो माय डियर फ्रेंड, दिस इज योर आइरिस ना. आइरिस इज डायलेटेड. This is your iris. ये आपका iris है. This is your iris which is dilated. This is your osseous ring. I hope it is clear. I am glad that you people are asking questions. You see, if you will ask the questions, I'll be able to clear your doubts. So this is going to be a two-way communication, which is a gold standard thing. That is why we are there conducting our eMedicoz app live sessions as well. Yes, no, this is not capsular axis, my dear friend Rachit. This is your osseous ring. Probably you have moved over to the next question. Yes, okay. All right. All right, so yes, there is some network issue at my end. Let me see. Okay, wait. Okay. Yes. Now coming on to this, which step of cataract surgery is being done? Now can you appreciate that this is the capsular flap which is being raised such that there is formation of CCC, continuous curvilinear capsular axis. So when you operate the patient, so you need to remove the capsular flap to create a window in the anterior capsule from which you extract the cataractus lens and you implant the artificial IOL whose power has been calculated before with the help of biometry. Yes, so this is capsular axis. But yes, what is lens aspiration, what is hydrodissection, and what is intraocular lens implantation? First let's see. So this is the process of your hydrodissection. So hydrodissection is after creation of the flap, so there is rim of the anterior capsule and the underlying lens. So you take a cannula, put it beneath the anterior capsule, inject the fluid. As the fluid flows, it is going to create the positive pressure posterior to the posterior surface of the lens, which is going to push the lens anteriorly and is also going to detach the lens from its around lying capsule so that you are able to eat it pretty easily. Yes, that is hydrodissection. And this is your what? This is your phacoemulsification. So you break the lens into small pieces and you aspirate it. You break it, you phacoemulsify it, and you aspirate it. So this is your phacoprobe by which, and there is a foot control by which you are aspirating. You are emulsifying and aspirating the liquefied lens. And intraocular lens implantation is when you are going to implant the artificial IOL after extracting the cataractus lens. But here you can clearly see that this flap is being created. Yes, and it is being created with the help of the capsular axis forceps. So the doctor is holding the capsular axis forceps. I hope it is clear. Yes, boys and girls, is it clear? Clear hai? Just a moment. I hope it is clear. So at my end, it is slowing down a little bit. Yes, okay. All right. Okay, yes, Doctor Study Life, I had shown you the entire cataract surgery video in the class. So right now in this session, so I'll not be showing any videos to make this session very crisp and concise, since this is a session which is just 14 days before your FMGE exam. But yes, if you'll see the real surgical video, if you want to see, you can go back to your DAMS-eMedicoz app and go to back to basics and revisit the cataract video where all the steps have been explained. Okay, now, okay, next is a child with a history of, so the answer to this question is rhexis. You are all aware of this, है ना? तो कैप्सुलर एक्सिस पे मार्क करेंगे. ओके, अ चाइल्ड विद अ हिस्ट्री ऑफ मॉल न्यूट्रिशन इज एग्जामिन्ड एंड द फॉलोइंग इमेज इज सीन. व्हाट इज द मोस्ट लाइकली डायग्नोसिस? व्हाट इज दिस इमेज? कैन यू अप्रिशिएट दैट द कॉर्निया इज hazy cornea? Now what do you get after seeing it? Hazy cornea which is bulging. Yes, now based on this, what do you feel can be your diagnosis? So first is boophthalmos. Now boophthalmos, of course there can be ground glass appearance of the cornea. The cornea may be hazy, but it will not bulge like this. So boophthalmos is eliminated. Megalocornea is just the increase in size of the cornea, but it will not be hazy, it will not be bulging. So this is also eliminated. Now corneal degeneration, if there is any corneal degeneration, you are going to appreciate some opacity, some haziness over the cornea, na? Yes, but again, but why there will be bulging of the cornea? No, my dear friend, it will not bulge like this. Yes, okay, ideally, yes. So the answer is anterior staphyloma also will take care of the history which is given. Now a child with a history of malnutrition is examined. So can malnutrition be associated with megalocornea? Another no. Can malnutrition be associated with congenital glaucoma? Another no. Can malnutrition be associated with anterior staphyloma? Absolutely. How? I am going to connect the dots because this is your previous year FMGE question and many students had actually connected with me and they had asked the same doubt in the class. Sir, how this history can be related to anterior staphyloma? Now please understand, if there is malnutrition, so there is one deficiency, that is your vitamin A deficiency, in which the patient will have xerophthalmia. When there is xerophthalmia, the first stage of xerophthalmia is, there will be conjunctival dryness. Remember bitot spots, kai bitot bolte hain, kai bitot bolte hain, X1B stage, bitot spots. Then there will be conjunctival xerosis. After that there will be corneal xerosis. Corneal xerosis means there will be drying of the cornea. Now if the corneal xerosis is there, if there is dryness over the surface of the cornea, and what is the function of the eyelids? So they are actually replenishing the tear film over the surface of the cornea. But when there is no tear film over the surface of the cornea, the patient is blinking. So I always give one example in my class. So you are driving a car and you want to wash the windshield of the car. What are you going to do? You are simply going to put on the windshield wipers. No, my dear friend, if you will do like this, you may induce the scratches on the windshield. Why? Because there will be some dust over the windshield. Yes. So you pull the lever towards yourself. First there is a shower and then there is movement of the wiper. The purpose of shower is to lubricate the windscreen. Some people even put some shampoo in the shower bottle under the bonnet to give extra lubrication over the windscreen. Yes. So when there is drying of the cornea and you are blinking, the patient is blinking, the normal blinking is every once in 10 seconds. So there is constant rubbing over the dry cornea, which will induce scratching over the cornea, which will induce drying and development of keratitis. Keratitis is inflammation over the cornea. This keratitis will lead to development of corneal ulcer. The corneal ulcer may eventually get perforated. When there is perforation of the corneal ulcer, there will be re-epithelialization of the perforated region of the cornea, which you will call as pseudocornea. This pseudocornea will start bulging because this is pseudocornea. This is not true cornea. This is your pseudocornea. It will start bulging, and this pseudocornea with uveal tissue incarcerated posteriorly, which is iris in this case, will be known as anterior staphyloma. Yes, I hope you have understood this. I hope मैंने जल्दी से आपको बताया है, डिटेल में नहीं बताया है, because we have to discuss another 20-22 questions, है ना? So this is the exact mechanism which is related with the history which is given. So this question was kind of tricky question. So there were a lot of dots connecting between the history and the image which was given. Yes. Okay, I hope you have understood. Now coming over to the next question, we are down with 4 MCQs, another 21 to go. I am telling you that this is going to be most crisp and most concise session. Please pay attention. Yes, okay. So identify the given lesion. What is this? Cornea is blue in color? Am I correct? No. Actually, I am seeing the cornea under a special light, which is your cobalt blue light. And what is this green thing you are seeing? So my dear friend, you stain the cornea with the special dye. The name of the dye is sodium fluorescein. This sodium fluorescein has the ability to absorb blue color and emit green color. And this happens if there is epithelial defect, which actually tells me that this is your corneal ulcer, and you can see some lesion like this. So this is your dendrite. So this is your dendritic keratitis. When this is your dendritic keratitis, now can you tell me in which condition are you able to appreciate the dendrites? Can you see in interstitial what is interstitial keratitis? This is just the stromal keratitis. See, the property of absorbing fluorescein dye is with the epithelium. When there is epithelium removal from the surface of the cornea, some raw epithelium cells are exposed, which will take fluorescein and will emit green light. But in interstitial keratitis, there is no involvement of epithelium, boys and girls. There is just the involvement of stroma. So how the fluorescein dye is going to enter into the stroma? Not possible. So interstitial keratitis, there will be no staining. Your previous year question. Fungal keratitis, you will see different set of features. The satellite lesions, dry looking ulcer, hypopyon. Yes, but here you cannot see anything like this. Even in fungal keratitis, you will see margins which will be very fluffy, non-defined margins. Here you can see defined margins. Just eliminate this. Bacterial keratitis, there will be a ulcer in which the margins will be clear cut and it will not give a picture like dendrites give. There will be hypopyon. There will be other features like the patient will have a lot of pain, which is not mentioned in the question. It can present in the viral keratitis, it can present in bacterial keratitis, interstitial fungal, all keratitis, pain will be present. But if we focus upon the morphology of the ulcer, so it is not looking like bacterial keratitis. So the answer is viral keratitis. Let me show you the images, because the idea is not to make you cram the things. Idea is to help you conceptualize. Can you appreciate this small lesion in the center? So this is present in the stroma. This is your interstitial keratitis. Now, can you appreciate the fluffy margins? Yes. Can you appreciate the satellite lesion? Can you appreciate the hypopyon? This is your fungal keratitis. Can you appreciate the central ulcer? Can you appreciate hypopyon? This is your bacterial keratitis. But we are talking of dendritic keratitis, in which fluorescein stain will give a picture of dendrites, which we can see in the question. So dendrites is the answer. All right, let's move ahead. I hope it is clear, guys. प्लीज अंडरस्टैंड, इसको एग्जाम से 4 दिन पहले दोबारा देख के जाना है. जो कुछ मैं कॉन्सेप्ट्स बता रहा हूं, आई कैन अश्योर यू इसमें से questions will definitely be there, if not from these 25 questions, but the concepts we are discussing here, है ना? Okay. Which nerve is implicated in the sign involving tip of nose in the given picture? बता दीजिए. ये this is the image of the real patient which I had seen 2-3 years back. बताइए. Can you appreciate the lesion on the tip of the nose? Can you appreciate the lesions here? And can you appreciate that the right eye, there is redness in the right eye? क्या लग रहा है आपको? What do you feel? What do you feel? So, boys and girls, this is a typical sign which is your Hutchinson sign. अब बताइए Hutchinson sign क्या बोलता है? पहली चीज, Hutchinson sign is present in a disease which is VZO, varicella zoster ophthalmicus, which is herpes zoster ophthalmicus. It is due to varicella zoster virus, which is chickenpox. Now, once the patient got chickenpox infection, the chickenpox virus is going to stay in the trigeminal ganglion. वो trigeminal ganglion में अपना घर बना के बैठ जाएगा. Yes? वो trigeminal ganglion में अपना घर बना के बैठ जाएगा और वो वेट करेगा कब पेशेंट की इम्यूनिटी कम हो. The virus will keep on waiting for the decrease in the patient immunity and will start flourishing. Now, if I talk about trigeminal nerve, just orally we are going to revise. In trigeminal nerve, there are three branches. One is ophthalmic division, another is maxillary division, and third is your mandible division. Now, ophthalmic division is having another branch, and that branch is your nasociliary nerve. So this is your ophthalmic nerve, ophthalmic division of trigeminal nerve. So there are three divisions. Now ophthalmic division is having nasociliary nerve, which supplies the cornea as well as the tip of the nose. Now if there are lesions on the tip or side of the nose, that means the virus has entered into nasociliary nerve, because I told you that nasociliary nerve supplies the tip of the nose as well as to the cornea. So if the virus has entered into nasociliary nerve, of course it is also going to enter in the cornea, because nasociliary nerve has got another branch which is long posterior ciliary nerve. Can you see this long ciliary nerve? So this is your long posterior ciliary nerve. What is the relevance? This nerve is actually forming the nerve supply of cornea. क्या हो रहा है जी? ये जो nerve है ना, ये cornea की nerve supply को बना रही है. So this is your Hutchinson sign, which actually tells me that if there are lesion on the tip of the nose or side of the nose, the corneal involvement is inevitable. Inevitable. Yes? Okay. Dear Dr. Janvi Patel, pseudodendrites can be seen in herpes zoster ophthalmicus. Yes, but they will be seen on the cornea. Here we are grossly seeing the patient and we are grossly appreciating. Yes? Okay. Now, not frontal nerve, not lacrimal nerve, not facial nerve. So, this is a clear-cut question, and that is your nasociliary nerve. I hope it is clear. I hope clear hai ji. Okay. Now, coming over to our next question. Commonest cause of benign intraorbital tumor in childhood. Now, as I always say in the class, that in our country, if you are not getting hara dhania and hari mirchi free with vegetables, you don't have a real feeling of buying vegetables, isn't it? So this question I purposefully added because we are not only going to answer benign intraorbital tumor in childhood, but also the other tumors which are associated and are your previous year questions. Now, first, commonest cause of benign intraorbital tumor. First, what about retinoblastoma? Yes, can you answer? Yes, boys and girls, retinoblastoma is not your intraorbital tumor. Intraorbital tumor is the tumor which is present inside the orbit. That means between the orbit and the eyeball, inside the orbit. But retinoblastoma is inside the eyeball, so it is your intraocular tumor. And mind you, this is your most common, your previous year question, malignant intraocular tumor in children, your PYQ. You got one हरी मिर्ची, हरा कैप्सूल मिल गया आपको. Now, what about choroidal melanoma? Choroidal melanoma means it is present inside the choroid. Choroid is not present inside the orbit, my dear doston. It is present inside the eyeball. So will it be intraorbital or intraocular? Again, this is your most common intraocular tumor in adults. ये भी नहीं हो सकता, ये भी नहीं हो सकता. These two cannot be there. Now, third, iris nevus. We are talking of the iris. So, iris is present inside the eyeball. So, nevus is a different thing. Iris nevus. If there is pigmented area over the iris, you can call it as nevus. But this will be intraocular. So, even if you don't know anything, still by the means of elimination, you can tell me that it has to be dermoid cyst. So, guys, this is how you approach a question. Let me tell you, there is not much difference between the top ranker in NEET PG and the one who has got 2000 rank. Just telling you, there is not much difference between a FMGE student who has got 160 marks or 180 marks. 20 marks difference. All that matters is that how you have applied the concept during the exam. The knowledge level between 160 and 180 and between top rank, top 100 and top, within 2000, it is all the same. It is all the same. But what matters is how you have trained your brain to be able to pull out the right answer, which is there in front of you already. You just have to identify that Bhairupia. Yes? Okay. So the answer is your dermoid cyst. Okay. Alright. Now, there are few images that I want to tell you. So, which is the most common malignant intraorbital tumors in children? Can you tell me? So, it will be your rhabdomyosarcoma. Rhabdomyosarcoma is your again PYQ, and it is seen in children intraorbital. Intraorbital means between the eyeball and the orbit. So there are extraocular muscles. There is going to be the tumor of the orbit. Yes. Okay. Next is, this is your dermoid cyst, which we have already discussed. It was a part of the question. Which is the most common malignant intraorbital tumor in adults? I am not saying intraocular. Intraocular is choroidal melanoma. I am talking of intraorbital. So it will be metastasis. Which is the most common metastasis? Non-Hodgkin's lymphoma. Okay. Which is the most common benign intraorbital tumor in adults? This is your cavernous hemangioma. Cavernous hemangioma. Yes. So I have given you so many MCQs. Based on this question. I hope it is well understood, boys and girls. Alright. So I have already given you the answer. Now moving over to our next question. Okay. Taiyar hain? Yes. Okay. Yes, Dr. Siddhant, Dr. Janvi, Dr. Gaurav, Dr. Sneha, very, very good. Orbital lymphoma, and most common cause of that orbital lymphoma is non-Hodgkin's lymphoma. Yes, okay. Now, what is the probable diagnosis of this image? ध्यान से देखेंगे क्या लग रहा है आपको. First identify. Don't again jump towards the options. So you can see dot, blot, soft exudates, fluffy margins. Yes. And what do you feel? What is this? So there are dot blot hemorrhages. There is presence of soft exudates. Now let's dissect each option one by one. So what do you understand by proliferative diabetic retinopathy? Proliferation means regeneration of your vessels. Can you see that there is any regeneration of the vessels? No. So this is not a proliferative diabetic retinopathy. Now, soft exudates and dot blot hemorrhages. Can you appreciate those in hypertensive retinopathy? No, because in hypertensive retinopathy, you see flame shaped hemorrhages, not dot blot type. So you remove it. Age related macular degeneration. So in this option itself, we are talking of the macula. But is this confined only to the macula? No, it is spread all across the retina. You can see here also, here also, here, 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 and ARMD will give a different picture. Even if you are not sure of the picture, just try to find the keyword age related macular degeneration. Yes, so typically it is your non-proliferative diabetic retinopathy. Yes, so this is how you again have reached towards the final answer by eliminating the options. So you will see hard exudates as well, which is not seen here, soft exudates, dot blot hemorrhages. There may be CSME, which is clinically significant macular edema. Now I am going to show you the different images. So here also, can you appreciate that there is regeneration of the blood vessels? Can you appreciate the very tortuous vessels here? So this is your PDR, which is proliferative diabetic retinopathy. But in here, in this image, you could not see that there is any regenerative vessels. But here you could appreciate that the vessels are regenerative, है ना? You could appreciate, okay, and you can see small dots like this. So what is the difference between hard exudates and soft exudates? Soft exudates are having fluffy margins and they are yellow white in color. Yes, and hard exudates, they are pale yellow in color and they have got defined margins. ठीक है जी? Okay, एक image और देखते हैं, एक second. अब ये देखिए, this is what? This is your fundus fluorescein angiography. This is your fundus fluorescein angiography. Now, can you tell me what are these dots? These are dots. This is your recent exam question. INICT NEET PG. उसमें से आया था ये question. So these are dots. Don't say that these are your dot blot hemorrhages. These are actually your micro aneurysms. पहली चीज. Second is, you can appreciate this hyperfluorescence on the retina. I have typically taken this image to guide you guys. If this image is asked, you should not mark it incorrectly. Yes, you can appreciate that there is hyperfluorescent area. This hyperfluorescent area depicts that there is leakage of the dye. Now this dye leakage happens to be from the areas of neovascularization. That means this dye depicts me that these are the areas where there is neovascularization. So it is seen in your proliferative diabetic retinopathy. It is seen in your proliferative. So this fundus fluorescein angiography is proliferative diabetic retinopathy. So Dr. Tia is asking, sir, soft exudates दिखेंगे क्या age related में? Dear Dr. Tia, soft exudates no, drusense yes. In age related macular degeneration, you will see drusense which will be more concentrated at the center towards the macula, and you will not see dot blot hemorrhages. Dot blot hemorrhages is due to loss of pericytes and they are seen in diabetic retinopathy. Yes, doc talk, hyperfluorescent, absolutely. ठीक है जी, I hope it is understandable. Okay, now coming over to the next question. Next question is kind of tricky. I am sure you will be able to tell me. Now on retinoscopy, let's first make the diagram. So on retinoscopy, at x-axis, the point of neutralization was minus 3.5 and at y-axis it was minus 1. And we used homatropine and the corrective factor for the homatropine is 0.5, while the corrective factor for 1 meter is -1. Now to put it into the equation, for the final subscription of power is -1 minus for the homatropine, -1 for the distance, minus 3.5 minus 0.5 for homatropine, -1 for the distance. So ultimately I have derived a power of -2.5 and -5 here. समझ पा रहे हैं? Now I need to prescribe this equation in the form of glasses to the patient. Now you need to understand what I am going to do is that I can either give -2.5 diopter sphere. If I give -2.5 diopter sphere, the sphere is going to act in both x-axis and y-axis. So this will become 0 because -2.5 is the power at y-axis. At x-axis I require a power of -5, but in the form of sphere I have compensated for -2.5 at x-axis. Now the remaining power which is left behind after prescribing the sphere is -2.5 at x-axis, isn't it? So I am going to give -2.5 diopter cylinder, because this extra -2.5 I require only at x-axis. So cylinders, they act only in one axis, while sphere, they act in both the axis, right? Now I am going to prescribe -2.5 diopter cylinder at, mind you, if I place cylinder at x-axis, it is going to act at y-axis, but here I need to give this power at x-axis. So I am going to keep the cylinder at y-axis because cylinders act opposite to the angle of placement. So if I want the power at 180 degree, I'll place the cylinder at 90 degree. So this is my one equation. Now if this equation is present in the options, no Baba Re, this equation is not there in the option. Let's go on for the second equation. What is that second equation? So I can either use an alternative equation. The alternative equation is I can give -5 diopter sphere. So this -5 diopter sphere will make the power at x-axis go null and void. But at y-axis we required -2.5. But in the form of cylinder, I have given in the form of sphere, I have given -5 because the sphere is going to act both at x-axis and at y-axis. Now, how do I decrease the power from -5 to -2.5 at y-axis? I am going to give +2.5 diopter cylinder. But in this case, I require this power. Where? At y-axis. I told you just a few moments back that if you are placing the cylinder at x-axis, it is going to act at y-axis. If you are placing the cylindrical glass at y-axis, it is going to act at x-axis. So here we require power at y-axis. So we are going to place the cylinder at x-axis. So this can be the alternative equation. Now let's look for this equation in the options. Do we have that? -5 diopter sphere? Sir, yes. +2.5 diopter cylinder? Sir, yes. 180 degree? Yes, yes, yes. So it is the final answer. This is how you derive the equation. If you want to understand retinoscopy in depth, you can go back to my YouTube channel. So I have put up retinoscopic video which is like 30-40 minutes long, where you can go on for understanding the entire conceptual retinoscopy, and we have solved many such MCQs there, right? So I hope you have understood. Okay. Yes, Dr. Tia, I have already told you. Yes. Okay. Now, which sign do you see here? So, can you see that there is some scleral show which is present? Yes. Now, which is this sign? So, this is a clear-cut answer. This is your Dalrymple sign. When there is upper eyelid retraction. This is your upper lid retraction, and it is seen in your thyroid eye disease. Von Graffe sign is your lid lag in down gaze. When you ask the patient to watch below, to watch inferiorly, so the eyeball will go down, but the eyelid will not go down along with the eyeball. Yes? Yes? I hope you have understood this. Okay. So, Stellwog sign. Stellwog sign is your infrequent blinking. Stellwog sign is infrequent blinking. Dear Dr. Raju, you can watch the video again or you can watch the entire retinoscopy video, है ना? तो एक बार देख लेना, नहीं समझ में आएगा तो you can always get back to me. Don't worry, I'll send you a voice note. Okay. I hope you have understood. Yes? Alright, Stellwog sign. Okay. So, yes, Hutchinson test is there. Hutchinson test you do in squint. That is not Hutchinson sign, Hutchinson test. There is no Hutchinson sign in ophthalmology. It is your Hutchinson test which you do in squint. You actually shine the light and you look out for the centering of the corneal light reflex. Yes? Okay. Alright. So what is this? This is your another sign which is your Cocker sign. It is your staring appearance which is again seen in thyroid eye disease. This is your lid lag in down gaze. Can you appreciate on looking down, this lid has gone down while this lid has not gone down, not down gone, है ना? Gone down. Okay. So this is your Von Graffe sign. Okay. Now, which of the following is correct? What do you see? Can you appreciate small dots in the lens? Okay. It goes in favor of what? Of course, it is your cataract. It is your cataract. But the question is incomplete. They have just given some random picture. They have just asked, what do you see? So based on this, first check out the options. Then we'll reach up to the answer. So probably most common type in children, visually significant, surgery, amblyopia. So probably they are talking of congenital cataract. Yes? Okay. Now congenital cataract, you can see small dots. So which type of congenital cataract, boys and girls? This is your blue dot cataract. Now let's eliminate the options one by one, keeping blue dot cataract in mind. So blue dot cataract visually significant? Nah, it is visually insignificant, although it is most common congenital cataract, but it is not associated with loss of vision. Eliminated. Yes, surgery is required as early as possible. Why surgery is required when it is visually insignificant? Yes, it is also eliminated. Amblyopia therapy should be started soon. Why there is any need to start amblyopia therapy when it is not leading to loss of vision? Why it will cause amblyopia? Amblyopia is stimulus deprived loss of vision. Na? There is no deprivation of the stimulus, because this cataract is visually insignificant. So the answer is pretty straightforward. This is your most common type of cataract in children. So this is another type of cataract which is most common cataract which is congenital but associated with loss of vision. This is your zonular or lamellar cataract. Zonular or lamellar cataract. This is your important PYQ. Yes? Okay. Now, the history is given. Okay. A 6-day after cataract surgery, a patient visits IOPD with complaints of sudden painful loss of vision. The following image is seen. So, the patient had cataract surgery just 6 days back. Yes. And you can see that there is presence of hypopyon. There is reddening of the conjunctiva, congestion. And the cornea is hazy. What is your diagnosis, boys and girls? Don't answer it directly. I want to know the diagnosis first. Yes, can you tell me the diagnosis? Diagnosis bata paoge? Yes, can you tell me the diagnosis, boys and girls? बताइए एक बार diagnosis बताइए मुझे, तब आगे चलेंगे. My idea is to not go for cramming. My idea is to make you conceptualize. Yes, diagnosis is, of course, the answer is, I know you are aware of, but what is your diagnosis, boys and girls? Diagnosis is endophthalmitis. Can you tell me the most common organism causing early post-operative endophthalmitis? It is staph epidermidis. If that is not in the option, go for staph aureus. If I talk about the late post-op endophthalmitis, the organism is Propionibacterium acnes. Yes. Okay. Now, what is the treatment of endophthalmitis? Endophthalmitis, there is inflammation of the choroid, retina, aqueous humor, vitreous humor, lens zonules. Yes. So, you are going to give intravitreal antibiotics. So, which antibiotic you are going to give? Vancomycin plus third generation cephalosporin. Yes. So, this is your treatment. Very good, boys and girls. I am so proud of you. Very good. This is how you should actively participate. Very good. Wonderful. Okay. Now, patient had a fight and is brought with non-reactive pupil with painful ocular movements. Most probable diagnosis is, so first, cataract. Are there any painful ocular movements? No. Why in cataract there will be painful ocular movement? And cataract will be slow, painless, progressive loss of vision. Here there is painful ocular movements and the pupil is non-reactive. In cataract the pupil will be reactive. In papilledema, what will happen? The pupil will be reactive or non-reactive? The pupil will be reactive in early stages, and the movements, the eye movements will not be painful. It is also eliminated. In glaucoma, of course, there will be pain, there will be loss of vision, but it will not be associated with ocular movements. And of course, in glaucoma, there can be non-reactive pupil in advanced stages. In advanced stages, there can be non-reactive pupil, but it will not be like the patient had a fight and suddenly there is glaucoma and the pupil has gone non-reactive. Does not make any sense. So this is also eliminated. Optic neuritis, yes, there is injury due to sphering of optic nerve, because you know the optic nerve forms the efferent of pupillary light reflex, and efferent of pupillary light reflex is formed by oculomotor nerve. So the answer is pretty straightforward. It is optic neuritis, and typical there will be painful ocular movements. So painful ocular movements may or may not be present in papillitis, which is inflammation of the optic nerve head, but it will definitely be present in retrobulbar neuritis, which means inflammation of the retrobulbar part of the optic nerve. Yes, I hope you have understood. Okay, this is also your previous year question. Okay. Next is, in which position is right inferior oblique tested? Now I have put an image here. Now, in simple terms, I know this is a hardcore conceptual topic of squint, but I want all of you to conceptualize it. If you want to appreciate the movement of your superior rectus, you will just ask the patient to abduct the eye, then look upwards. That is, so there is the question, sir, but option A and B can occur due to trauma as well. Option A and B, option, dear Dr. Tia, so non-reactive pupil is not associated with cataract, na? So the patient had a fight and is brought. That means this condition is immediate. Cataract will not happen just in few seconds or few minutes or even in days. It will take some time. Cataract will take some time. I understand you may be talking of the cataract associated with blunt trauma, but why the pupil will be non-reactive? Why there will be painful ocular movements not associated with cataract, na? Papilledema. Papilledema is when there is probably head trauma is there, hai na? Head trauma, there is raised intracranial pressure, but for the development of papilledema, it will take at least 3-4 days. It will not be immediate. And even if there is development of raised intracranial pressure, which will compress the optic nerve head, which will lead to papilledema. The pupil will be reactive. Remember, I had told you in papilledema that the vision is not affected till late. If papilledema is associated with secondary optic atrophy, then there will be non-reactive pupil, then there will be loss of vision. I hope you have understood. Okay. Now, in which position is right inferior oblique tested? So there is a simple funda. I am just going to do touch and go because otherwise it will become a very long topic to discuss. So which muscle is elevator in abducted position? If you want to appreciate the lone action of the superior rectus, so you will ask the patient to abduct the eyeball, then look upwards, because there is some angle between the orbital axis and the visual axis and the muscle plane. So please understand, the eyeball is seeing straight ahead, but the orbits are divergent. So there is some angle between the muscles. This is your extraocular muscle of the right eye, the superior rectus and inferior rectus. This is the placement of the eyeball. So if you want to appreciate the lone action of superior rectus, the single action of superior rectus, you ask the patient to look towards outside and then ask the patient to elevate the eyeball. So you can appreciate here, if there is dextro elevation that the patient is looking towards the right and then the patient is elevating the eyes, right? So this action you can appreciate. So right eye superior rectus will be there and left eye inferior oblique will be there. Now if I want to appreciate the action of lateral rectus of the right eye and medial rectus of the left eye, I'll ask the patient to look onto the right side. You call it as dextroversion. In dextroversion, OD means right, OS means left, OU means both eyes. OU means both eyes. I hope it is understandable. Okay. Now if you ask the patient to dextrovert, so right lateral rectus and left medial rectus. Now if you want to appreciate the muscles of the right eye, which is inferior rectus, and the muscle in the left eye, which is superior oblique, you ask the patient to look onto the right side and below. So in this position, you are going to appreciate inferior rectus in the right eye and superior oblique in the left eye, because in this position you will have the single action of inferior rectus in the right eye and single action of superior oblique in the left eye. Yes, I hope it is understandable. Similarly, if you want to go for levo version, so left side, left lateral rectus, right eye, right side, right medial rectus. Now, if you want to go on for levo elevation, so left superior rectus and right inferior oblique. If you want to go for levo depression, left inferior rectus and right superior oblique. This is a very hardcore concept. Yes, so just go through this topic of squint once again if you have not understood. Yes, and then you can get back to me. So here, now getting back to the question, in which position right inferior oblique is tested? So you want to test the right inferior oblique, you just ask the patient to look onto the left side. Right inferior oblique, what is the action of right inferior oblique? It causes elevation in the adducted position. So you ask the patient to look onto the left side, so right eye is adducted, and then you ask the patient to elevate, so that position will be levo elevation. So that is the clear-cut answer here. Dr. Jay, there is no mnemonic of this, and you will have to understand this conceptually. Yes, okay. Now a 20-year-old patient came to OPD with bilateral irritation and itching in the eyes. On examination, the following picture is obtained. All are true except, so what is this? You can appreciate that these are your cobblestone papillae. Typical history of allergy which is given. Bilateral, 20-year-old means nearly a teenager, and there is itching. So this is allergy. So which of the following is false? More common in summers. Yes, the name of the disease is vernal keratoconjunctivitis, which is also known as spring catarrh, but it is more common in summer, so it is correct. But they have asked about the incorrect option. Antibiotic eye drops to be administered, yes or no? We are going to come in a short while. Corneal ulcer may develop. This is your previous year FMGE question. The name of that ulcer is typically shield ulcer, which may develop. More common in males. Yes, it is more common in males. Antibiotic drops are not administered. You will give antihistaminics, which is olopatadine, which is new generation antihistaminic. I hope it is understandable. Okay. And what are the other features that you are going to see in vernal keratoconjunctivitis? You are able to appreciate the mucoid nodules at the limbus, and these are your Horner Tranta spots. This is your pseudo gerontoxon, which appears to be like a peripheral corneal opacity. So इस टॉपिक में से अगर कोई क्वेश्चन आया तो गलत नहीं होना चाहिए. This is your typical shield ulcer. All right, wonderful. Next is a hypermetropic patient with closed angles on gonioscopy, has IOP of 15. Okay, IOP is within normal limits, but the angles are closed with optic disc as in figure with normal fields. So what is the diagnosis? So here, can you appreciate any signs of glaucoma? There are no features of glaucoma on fundus examination. Isn't it? You can see that the CD ratio is within normal limits. When do you suspect glaucoma? You suspect glaucoma when CD ratio is more than equal to 0.7. Here it is approximately 0.3, 0.2 to 0.3. But they are saying that the angles are closed. Yes. Now, what is your diagnosis? Now, if you have not understood this question conceptually, you will simply go on for saying that, sir, it is a case of primary angle closure glaucoma. But my dear friend, this is not your primary angle closure glaucoma. What is the definition of glaucoma? Glaucoma is when there is raised intraocular pressure which damages the optic nerve head. But in this case, there is no raised intraocular pressure. There is no optic nerve head damage. So how can you call this as glaucoma? So you will first and foremost eliminate primary angle closure glaucoma. What is ocular hypertension? Ocular hypertension is when there is just the raised intraocular pressure, but there is no visual field change, there is no optic nerve head changes. This can also not be there because the IOP is given, which is well within normal limits. The normal limit of IOP is 10 to 21 millimeter of mercury, which is normal. Yes, but this is not ocular hypertension. Now we are left with primary angle closure suspect and primary angle closure. As per definition, if there is narrow angle of anterior chamber and there is no raised intraocular pressure, you call it as primary angle closure suspect. But if there is narrow angle of anterior chamber and there is raised intraocular pressure or there is synecdoche formation, then you call as primary angle closure. But in the question, have they mentioned about synecdoche formation? They have just mentioned about the closed angles. They have not mentioned about raised intraocular pressure. It is normal. So the answer will be very good, all of you. Yes, the answer is primary angle closure suspect. So there are three terms: primary angle closure suspect, so normal IOP and normal optic disc, which was the question. But if there is increased IOP or they have specifically mentioned about synecdoche, yes, then you may think of primary angle closure. But if there is optic nerve head damage, means raised CD ratio, nasalization, bayoneting sign, laminar dot sign, then you will think of primary angle closure glaucoma. All right. Now coming on to the next question. Which of the following Z-plasty procedure is used? What is ankyloblephron? It is adhesion between it is adhesion between upper and lower eyelid. Yes, okay. Ectropion and entropion. Ectropion is outward rolling of eyelids. Entropion, inward rolling of eyelids. Symblephron is when there is adhesion between the palpebral and bulbar conjunctiva. These can be asked as single terms. Bulbar conjunctiva. Now they have asked about the Z-plasty procedure. So boys and girls, Z-plasty procedure is done in ectropion. This you will have to remember. So the definition I have told you. So Z-plasty is this. So you give a Z-shaped incision and then you suture it so that if the eyelid is turned outside, it is then turned inside. Yes, that is Z-plasty. You can go on for another surgery in ectropion, that is your VY procedure. You will give a V-shaped incision, then you extend it towards Y, and that is your again seen in ectropion. All right. Now this is also your previous year question FMG, but since many students ask me, so I have included this in this session. Okay, which of the following is synergistic muscle of left lateral rectus? What do you understand by synergism? Synergistic muscle which is helping left lateral rectus. What is the action of left lateral rectus? So it causes abduction. So out of the given options, which muscle will assist the left lateral rectus in abduction? How will you reach towards the answer? Because we are talking of the assistance of the left lateral rectus in abduction. We will simply eliminate the options which are associated with the right eye, because we want to move the left eye in abduction now. So there is no point of taking the right muscles. Yes, now we are left with left inferior oblique and left medial rectus. Even if you don't know anything, so can left medial rectus have a synergistic action? No, it is going to have an antagonistic action. Why? Because the left lateral rectus causes abduction while left medial rectus causes adduction, opposite action. Now, how can it be synergistic? It cannot be synergistic. Yes, so you can eliminate this. The answer is left inferior oblique. Otherwise, oblique are abductors, recti are adductors. So, left lateral rectus causes abduction of the left eye, and we are talking of the inferior oblique. So oblique are abductors. That means the inferior oblique also causes a little bit of abduction. So of course this is an action which is in synergism with that of left lateral rectus. So that is the answer here. I hope you have understood. Okay, now these are the actions of the muscles you should know. I have already told you the mnemonic. Oblique are abductors, recti are adductors, superior are intortors, inferior are extortors. Okay. Now a child is being considered for IUL implantation. What should be kept in mind in such a case while choosing IUL power? Now please understand, समझेंगे इसको. Now the size of the eye in a child is small. You want to operate the patient with the cataract. So you are going to perform biometry. Biometry is the calculation of the intraocular lens power. Just listen to me, hai na? So that we can save the time of writing. So what are the components of biometry? First you will go on for keratometry. Keratometry is the assessment of the power of the cornea. Second, you will go on for doing A scan. A scan is you measure the axial length of the eye. Now, the axial length of the eye at birth is 16.5 millimeter, while adult axial length is 24 mm. So, when you calculate the IUL power by calculating the axial length in a child, the IUL power will be relatively high. But when the child will grow, the eyeball size will also grow, hai na? And as a result of which, if you have used the high IUL power You also know power is inversely proportional to focal length. Now, if this is the eyeball, this is the lens, this is the retina. Now, if you place the lens of the power of plus 20 diopter, now this is going to project the light on the retina in a child, and the axial length is 16.5 millimeter. But when the eyes will grow with age, the increase of the axial length will be there, such that now it has become 24 mm in adult. But because you have placed an artificial lens inside the capsular bag, had there been the natural lens of the patient, it would also have been grown as per the growth of the eye, so that even after attaining the adult size, the rays of the light would project on the retina. But here you had put in the artificial lens. So this lens is not going to change its power, but the focal length of the lens as was calculated when the size of the eye was 16.5 mm, it will remain the same. But the retina has gone posteriorly due to increase in the size of the eyeball. So the patient will become post-operative after some time myopic. So that is a major challenge while operating pediatric cataract surgeries. Have you understood? Yes. So how can you null and void this phenomena? You will do undercorrection. If the age of the child is 0 to 2 years, and with the help of biometry, if the power comes out to be plus 20 diopter, you are not going to implant the lens of 20 diopter. You are going to do 20% undercorrection. You are going to implant the lens of plus 16 diopter, so that after some time, when the retina goes far posterior, the image is projected exactly on the retina. And if the age is 2 to 8 years, you will do how much of correction? 10% of the correction, such that you are going to implant the IUL of plus 18 diopter. This is the IUL correction that you perform while operating a patient with congenital cataract, if you are operating from 0 to 8 years of age. So the answer is clear cut. There will be myopic shift. I hope you have understood. Okay. Now coming on to the next question, which of the following is true regarding cortical blindness? Now for that, you will have to understand quickly. Now if you shine the light into the eye, it is going to strike the retina, from where it will go into the optic nerve. From optic nerve, it will go into optic chiasma, then optic tract, then pretectal nucleus of the midbrain, then it will go towards internuncial fibers and supply both Edinger-Westphal nucleus, pretectal nucleus, Edinger-Westphal nucleus, from where the impulse will follow through the oculomotor nerve and both pupil will be constricted. Yes, this is the normal pupillary light reflex. But now check out this beautiful image. So this is again forming the pupillary light reflex. But here lies the cortex. Cortex means which interprets the vision. Did you notice something? If there is any damage to the cortex, is there any obstruction of the formation of the pupillary light reflex? No, because the pupillary fibers, they are passing from the optic tract to the pretectal nucleus. They are not passing through the cortex. So even if there is damage to the cortex, that means if the patient has gone blind, if there is occipital lobe stroke, if the patient had occipital lobe stroke, such that the cortex, occipital cortex, where there is visual area, which is area 17, it has gone dead. Even after this, the pupillary reflex will be normal or abnormal? It will be absolutely normal. So direct and consensual reflex will be present in both the eyes. This is very conceptual. Even if there is complete loss of vision, because the pupillary light reflex fibers, they don't pass through the cortex. They pass through pretectal nucleus. All right. Now, most common complication of the following pick. Now you need to tell me, what is this? This is your Coloboma. Coloboma is absence of tissue. This is your coloboma of the upper eyelid. Yes. Now, in this situation, when the patient is going to sleep, yes, when the patient is going to sleep, since it is on the upper side, so you know there is a phenomenon, you call it as Bell's phenomenon. There is a Bell's phenomenon. Bell's phenomenon is a normal phenomenon. When the patient, yeah, any person who closes the eyeballs will roll up and outside. But when this eye is going to roll up and outside, so this part of the eyelid will not be able to cover the cornea. And while sleeping, this part of the cornea will remain exposed to the external environment, due to which there will be drying of the surface of the cornea, which will induce inflammation, which may lead to corneal ulcer. So this you call it as exposure keratopathy. Since there is a defect in the eyelid, how the cataract will be associated? No. Is there any loss of vision? No. Why amblyopia? Amblyopia is stimulus deprivated loss of vision. Restricted movements. Why the defect in the upper eyelid has to do with restricted eye movements? Not at all. So the answer is pretty straightforward. It is exposure keratopathy. Fascianella servate procedure is done for this. You will have to remember. I am quickly going to tell you. So Fascianella servate procedure is when you cut the part of conjunctiva, you cut the part of molar muscle, you cut the part of tarsal plate. So that is why you call this as conjunctivo-mularo-tarsectomy or conjunctivo-tarso-mularectomy. Yes. So it is done in ptosis. But which form of ptosis you go on for? So you go on for mild ptosis, because in mild ptosis you have got good levator palpebral superioris action. That is your Fascianella servate procedure. If there is sphere ptosis means that the patient is having very poor LPS action. So you go on for frontalis brosling surgery. Even in jaw winking syndrome, you go for frontalis brosling surgery. Fascianella servate is contraindicated in cicatricial. Contraindication in cicatricial means post-scarring ptosis. Yes. And frontalis brosling is this. So this surgery is the surgery of choice in moderate and severe ptosis. Moderate and severe ptosis. Moderate and severe means if the ptosis means congenital. I am talking of congenital ptosis, frontalis brosling, if it is more than equal to 2 millimeter. If the drooping is more than equal to 2 millimeter. Sir, in 21 question, the management will be tarsorrhaphy. Yes, you can go on for tarsorrhaphy. You can even go on for tissue grafting. You can take the tissue from behind the ear. Better is that, because in tarsorrhaphy you will keep the eyes closed and you will do tarsorrhaphy if there is keratopathy. That is to treat keratopathy. And once the keratopathy is treated, once the ulcer is healed, what you will do after that? You will have to close this region, so that now once the patient sleeps again after the treatment of corneal inflammation, so there should not be reappearance of the condition. So ultimately you will do grafting, you will do skin grafting over the area to prevent recurrence of the disease. Okay. Dear Dr. Doc Talk, I am not showing any real patient videos. Sorry for that, because otherwise it is going to take a lot of time. Hai na? For that you can revisit my FMGE live app lectures, or you can watch back to basics if you are a NEET PG student. Yes. Okay. Now the most metabolically active layer of the cornea is, so as I always say, A, B, C, D, E. A for anterior epithelium, B for Bowman's layer, C for corneal stroma, D for duas and descendants, E for endothelium. Endothelium has sodium potassium pumps which throws 3 sodium inside the anterior chamber and take 2 potassium inside the cornea, due to which the water follows the 3 sodium ions and the cornea is maintained in dry state. This endothelium helps in maintaining transparency of the cornea. Now, since it has got sodium potassium pumps, so it use ATP. That is why it is the most metabolically active layer. Stroma forms the bulk of the cornea. Descemet's membrane is strongest layer. If Descemet's and Duas is given, so you are going to pick Duas over Descemet's. This is a recent change. Duas over Descemet's strongest. Endothelium, no, not epithelium, endothelium. Yes, epithelium is superficial most layer, and it consists of further 6 to 7 layers of epithelium cells. Okay, can you tell me what is the normal endothelium cell count, ECC? Normal endothelial cell count in adults is 2700 to 3000 cells per millimeter square. How do you measure the ECC? By specular microscopy. How do you measure the thickness of the cornea? The normal thickness of cornea is 500 to 600 micron. You assess it with the help of tachymetry. Yes? Okay. Now, rupture of Descemet's membrane is seen in. So, rupture of Descemet's membrane. So, corneal dystrophy. So, why in corneal dystrophy you are going to see rupture of Descemet's membrane? No. Rubella? No. Interstitial keratitis, I have already told you, we have already discussed. It is just the inflammation of the stroma. In keratoconus, there is thinning of the cornea. Thinning of cornea. Now, due to thinning, there is a stretch which is induced on the cornea. So, there is stretching of the Descemet's membrane. Stretching of Descemet's membrane. So, in some cases, it may lead to rupture. But if it is specifically asked, the rupture of Descemet's membrane, it is seen in Harb's striae in congenital glaucoma, while in keratoconus, in initial stages, there is stretching of the Descemet's membrane. This stretching is known as Vogt striae. Don't confuse Harb's striae with that of Vogt striae. V for Vogt, V for vertical striations. H for Harb, H for horizontal striations. Yes, and this is stretching of DM, which ultimately may get ruptured. This is also your previous year FMGE question. Okay, all right. Coming over to the last question. Fundus of a young patient shows pigment along retinal mid-periphery. And can you appreciate the typical morphology of the pigment? This is your bony spicule pigmentation. And can you appreciate the pale and waxy disc? Can you also appreciate the thinning of the blood vessels? You call it as attenuation. This is forming a typical triad of one disease, boys and girls, and that disease is retinitis pigmentosa. How will you eliminate the other options? Here you are going to see dot, blot, hemorrhages, exudates which are not here, central serous retinopathy, no pigment, there will be normal optic disc, the blood vessels will be normal in size, there will be no attenuation, lattice degeneration of retina is entirely a different thing, there will be no effect on the attenuation of the vessels, no effect on the waxy disc, no effect, no, there will not be any bony spicule pigmentation. Yes? Okay, so boys and girls, so these were your 25 MCQs. I have tried to approach these questions in a very crisp and concise manner. Thank you for giving me your extra 20 minutes. The basic idea was to teach you not only the concepts but also to help you eliminate the options which will be very pivotal in getting beautiful score in your FMGE exam. And if you have further doubts, you can always get back to me. 9814111330. I am available on WhatsApp. You can also be a part of my Telegram channel, which is Ophthalmology by Dr. Manish Chhabra. You can also follow me on Instagram, which is I_Manish. Any doubts anywhere, you can get back to me And Dr. Adi is asking, Sarji, the stage of NPDR important? Yes, my dear friend. So in 2023 January session, they had asked about the criteria of very severe NPDR. Yes, so it is important. You'll have to go through it. Mild, moderate, severe, very severe. In mild, there is only microaneurysms. Moderate, microaneurysms, dot blot, hemorrhages. In severe, there is a 4-2-1 rule. Hemorrhage in all the 4 quadrants, 2 venous bleeding, and 1 IRMA, intraretinal microvascular anomaly. So out of 4 to 1, 1 should be present. Anyone, either hemorrhage in 4 quadrants, either 2 venous bleeding, either 1 IRMA. In very severe NPDR, there should be more than 2 things out of this 4 to 1. 2 things means 4 hemorrhages quadrant and 2 venous bleeding. Yes, it is very severe. Hemorrhages in all 4 quadrants or 1 IRMA. Yes, very severe. Or 1 IRMA or 2 venous bleeding. Yes. This is NPDR. If we talk about PDR, there should be proliferation, neovascularization, the image of whom which I showed you. I hope it is well understood. Yes, boys and girls, I hope it is well understood. Any doubts you have, please feel free to get back to me. I am always here to help you guys, always here for you. We at DAMS, our idea is to be available for all of you students, all 24/7. Thank you very much. As always, it is always my pleasure, and thank you again for giving me your extra 20-25 minutes. And yes, that's it. We'll see each other soon after the results of FMG. मुझे जरूर बताना कैसा result आया. So I'll also want to be a part of your success once your results will come. Thank you very much. It is all my pleasure. This is Dr. Manish Chhabra, your DAMS ophthalmology educator, signing off. Yeah.